factors such as the number and improved quality of completed and ongoing studies and the successful outcomes of these studies lead us to conclude that the adolescent treatment specialty has entered a Renaissance historical era. At the same time, we've made only minimal progress in transporting evidence-based therapies into routine care settings. The best treatment programs are multi-component. They provide a combination of therapies and other services to meet the needs of the individual patient. These key program elements for an adolescent treatment program are summarized in an influential report, Treating Teens, a Guide to Adolescent Drug Programs. In this report, the Drug Strategies Expert Panel identified 9 key program elements. 1. Assessment and treatment matching. Programs should conduct comprehensive assessments that cover psychiatric, psychological, and medical problems, learning disabilities, family functioning, and other aspects of the adolescent's life. 2. Comprehensive, integrated treatment approach. Program services should address all aspects of an adolescent's life. 3. Family involvement in treatment. Research shows that involving parents in the adolescent's drug treatment produces better outcomes. 4. Developmentally appropriate program. Activities and materials should reflect the developmental differences between adults and adolescents. 5. Engaging and retaining teens in treatment. Treatment programs should build a climate of trust between the adolescent and the therapist. 6. Qualified staff. Staff should be trained in adolescent development, co-occurring mental disorders, substance abuse, and addiction. 7. Gender and cultural competence. Programs should address the distinct needs of adolescent boys and girls, as well as cultural differences among minorities. 8. Continuing care. Programs should include relapse prevention training, aftercare plans, referrals to community resources, and follow-up. 9. Treatment outcomes. Rigorous evaluation is required to measure success, target resources, and improve treatment services. These 9 program elements offer a yardstick for programs to assess how they stack up against the best practices in the field. Group counseling approaches for teen drug problems still prevail in the field. This is likely based on tradition, economics, and the slow pace of change in professional training programs rather than available data about best practices. Although certain group-based approaches for teen drug problems have been shown to be effective, particularly cognitive behavioral therapy approaches, more research has been conducted on family-based treatments than any other modality for adolescent drug treatment. Numerous scientific reviews, practice guidelines published by professional societies, and government and foundation reports confirm that certain family-based treatments are highly effective in treating teen substance abuse, as well as other behavioral problems, including delinquency. These approaches can also improve family functioning, school performance, mental health functioning, and the symptoms that accompany co-occurring disorders. Family-based therapies have a well-defined theory basis. They use research-derived knowledge about the known determinants of teen drug use and delinquency, and they have clearly organized treatment manuals. Treatments succeed or fail depending on their capacity to engage and retain clients. Engaging teens in treatment can be difficult. In one national study, only 27% of adolescents completed a standard 3-month outpatient treatment program. That means that over 7 in 10 teens quit the treatment program prematurely. Typically, this finding is interpreted as proof of adolescent resistance or evidence of the inevitable difficulty of treating teenagers, but looks can be deceiving. New evidence indicates that this understanding of why so many teens fail to show up for or remain in treatment is too narrow. We can also understand low engagement and retention or high dropout statistics in terms of ineffective or outmoded treatment strategies. We know now that developmentally inappropriate, punitive, or get tough approaches, shock incarceration, or boot camp, for instance, simply don't work. In fact, these interventions can produce harm. Broadening our frame also includes therapist factors in accounting for outcomes. Therapist skill matters. Compared to usual treatment, family-based therapies demonstrate dramatic improvement in initial therapy engagement and completion rates. These family-based therapies now routinely show engagement and retention rates between 70 to 98%. Early reviews were cautiously positive about the available science supporting family-based treatment. The term we used to describe the status of the scientific evidence about a decade and a half ago was promising but not definitive. But recent reviews nominate family-based therapies as the treatment of choice for adolescent substance abuse. Next, to illustrate some of the developments we've discussed so far, I'll focus on one of the well-established family-based treatments, multidimensional family therapy.